Hi everyone, thank you so much for watching this presentation of our paper, Leveraging Implementation Science in Human-Centered Design for Digital Health. I'm Alex Waddell, an implementation and behavioural scientist working at Action Lab in Monash University, Australia. This paper, included in CHI 2024 Health Track, aims to provide a practical approach for designers to use implementation science in practice by combining two well-known frameworks: the double diamond approach and the non-adoption, abandonment, scale-up, spread and sustainability framework, or NASSS. In this presentation, I will cover the motivation for this work, an example application of the approach, and next steps. Before beginning, it's really important to position this work. When discussing digital health interventions, we are referring to those interventions that are evidence-based and aim to be used in practice in health organisations or systems. I'd like to thank the team behind this paper, including my colleagues from Action Lab at Monash University, Australia, Turning Point, Eastern Health, and Oxford University. So there's been a rapid increase in the number of digital health interventions in the last few years, especially through COVID. And these interventions promise to increase reach, equality, and use of evidence-based information for the public good compared to non-digital counterparts. HCI has contributed significantly to the design and development of the interventions through deep engagements with end users and communities. However, in many cases, digital health interventions are designed or created but not implemented and scaled, leading to the term pilotitis, a critique of pilot projects that don't lead to larger scale implementation. The challenge of moving beyond pilot projects to larger scale implementation is a significant issue. A huge amount of time, resources, and community goodwill is devoted to these projects that might not see result in meaningful impact for communities. And this is especially important to address in resource-constrained settings, such as public health systems, low and middle income countries, and working with marginalised communities. Furthermore, many health interventions, not just digital ones, face issues with research waste. It's estimated only 1 in 5 make it to routine practice, while due to traditional creation of evidence in health and a linear pathway, such as randomised control trials, it takes on average 17 years for evidence to reach the intended population. There are lots of different factors that influence digital health interventions failing to reach real-world practice. And one crucial factor, and the motivation for our paper, is that many health interventions are not adequately considering implementation factors in the design process. And this has just been discussed extensively in the paper and in the literature. And we just guide you to the paper for an in-depth discussion of this. Implementation science tackles these challenges head-on. Implementation science is the scientific study of methods to increase the uptake, implementation, and maintenance of evidence-based interventions, practices, and policies in real-world settings, and draws on foundations in psychology, public health, social science, business, and health professions. Essentially, implementation science attempts to speed up the research pathway and to ensure evidence-based practices reach the intended populations as intended and can be scaled and maintained over time. For newcomers to implementation science, a useful analogy is that evidence-based interventions are like a drug or pill, and implementation science is used to scientifically explore how the pill is delivered. The strategies used to get the pill delivered are called implementation strategies. And most interventions will require changes to individuals' behaviour, changes in organisations, and changes in systems to get the intervention to the intended population. Implementation science helps us to understand and plan for implementation of evidence-based interventions through a number of theories, models, and frameworks. But it can be really hard for newcomers as there are over 150. This has motivated our selection of just one framework to focus on. The idea of combining HCI and implementation science is not new. However, research to date on how to combine the two areas has mostly been reported in health journals and looks at how implementation scientists can use user and human-centered design, rather than how designers or those working in HCI might be able to use implementation science. Last year, Kai had a fantastic workshop run by Aaron Lyon and Sean Munson and colleagues to workshop how to combine the two. However, bridging the two remains relatively abstract, and there are calls from researchers in both fields to clearly integrate frameworks to bring the two fields together and to explicitly describe how to design for implementation. Our paper aims to address these gaps and provide a practical way to integrate implementation science within design of digital health interventions. As mentioned, there are many different implementation science frameworks to choose from. Determinant frameworks are those that attempt to identify different contextual factors that influence implementation. Determinant factors are thought to be the most suitable for designing interventions because they seek to explore and understand influences across different levels. This helps designers to consider individual, organizational, and systems within their design. NASSS is a determinant framework that allows researchers to surface and explain the multiple influences on the adoption, scale-up, and sustainability of technology in health and social care. Developed by Greenhall and colleagues at the University of Oxford, it is one of the only frameworks that focuses on the implementation of technology and includes technology-specific considerations that aim to move technology past pilot projects and into organizations as business as usual. NASSS includes 7 domains shown on the screen: the condition, the technology, the value proposition, the adopter system, the organization, the wider system, and emergence over time. In exploring the implementation of a digital evidence-based intervention, users are asked to consider the complexity involved within each domain. Each domain can be considered to be complex, complicated, or simple. Greenhall and colleagues argue that a technology is more likely to fail if there are multiple domains of complexity. In other words, using NASSS helps you to look across different domains and highlight where complexity might get in the way of implementation. In our approach, we combine NASSS with the well-known double diamond process from the British Design Council. The double diamond has been used extensively in design of digital technologies and provides a structure through 4 phases of diverging and converging thought. Discovery to explore the problem space, definition to make sense of and analyze, to define the challenge and create a design brief, development to create and refine possible solutions to the brief, and to delivery to prototype, to extend and refine possible solutions. The double diamond allows practitioners to pick and choose the methods that suit their needs, and importantly, isn't necessarily a linear process and can involve moving iteratively across and within each phase. We use the double diamond as a scaffold to explore each NASS domain and attempt to reduce complexity where possible. I'll take you through the overarching steps within the approach, but I encourage you or those interested to read the final paper for a more detailed explanation of each step, as this will be a quick overview. It's important that the team establish the issue to be solved using an evidence-based intervention delivered via technology, the likely end users of the technology, and the system or organization in which it will be implemented prior to starting this approach. The issue we were brought in to solve was trying to use a brief digital health intervention called Health for Her to decrease consumption of alcohol in women attending breast screening services. Alcohol is the leading modifiable risk factor for breast cancer in women, even in very low amounts. Approximately 1 in 15 breast cancer cases are attributable to alcohol consumption, and 1 in 5 breast cancer deaths. Yet awareness of this risk remains really low, especially among mid-older aged women who are at the highest lifetime risk for developing breast cancer and who are drinking at increasingly risky levels and for whom health information on this risk is not systematically provided. There is considerable evidence for brief digital alcohol interventions in reducing alcohol consumption. However, we believe this was the first of its kind to deliver the intervention in a breast screening service. Health for Her was trialled at Maroondah Breast Screen in 2021, but needed to be redesigned for a number of reasons, which you can read about in the paper. Essentially, the initial design did not reduce alcohol consumption, although it did increase knowledge and health literacy and was acceptable to women and staff. The intervention, as it was, would be really difficult to maintain as it required women to sit in the waiting room and use an iPad following their appointment to receive the intervention. Staff were not sure that this could be maintained as they didn't have the resources to troubleshoot the iPads, and many women were not able to stay after their appointment. We saw the redesign of Health for Her as a great study to utilise our approach of integrating implementation science principles within the design of a brief alcohol intervention for implementation within breast screening services. Again, for a detailed overview of the approach, please see the paper. But as you can see, our approach works through each phase of the double diamond, from problem statement through design brief and to final solution, and asks users to consider both the domains of NASS and the complexity associated within each domain. As a reminder, the domains are the condition, the technology, the value proposition, the adopter system, the organisation, the wider system, and emergence over time. For a detailed explanation, again, please see the paper. In the discovery phase, we want to use NASS to scaffold our exploration, to understand and to question the design problem and explore the needs of potential users and other relevant stakeholders. This ensures we're focusing on a broad range of factors that can affect implementation and to explore potential implementation strategies. Put simply, we need to ensure we speak to a broad range of stakeholders and consider different sources of evidence. In the definition phase, we use NASS to analyse and synthesise the findings and to surface potential issues to address in the design brief. We also want to understand how complexity is involved, and this will eventually culminate in a design brief. In the development phase, designers are encouraged to find possible solutions to respond to the design brief. And then, in the delivery phase, it's crucial that implementation measures are embedded in the testing of the intervention. This is a brief overview of the methods we used: systems mapping, an ex-post analysis of previous trial and literature review, co-design workshops with women for discovery. In definition, we used thematic analysis using the NASS domains and prioritised the design brief. In development, we ideated potential solutions by contextualising existing evidence. We validated the design assumptions, and we needed to actually add an additional pilot arm within the trial. Prototype testing and design iteration was part of the delivery, with focus group discussions with clinic staff members and trial implementation and evaluation. Again, for a full explanation, please see the paper. So, reflections, limitations, and next steps. This approach really needs a team approach and expertise from different disciplines. This idea of using the NASS extends who is considered an end user, and it encourages people to think through who else might be involved from an organisational and system level. There were a lot of limitations on the design, considering that we're in a healthcare context and actually needed to be designing with a randomised controlled trial in mind. And NASS is one of many different implementation science frameworks, and we do believe that other implementation science frameworks could be embedded in the double diamond in a similar approach. This is just the beginning of this approach, and we would love to talk to others and to share reflections on what it means to combine implementation science and digital design. Here are some of the references, but again, please do see the paper. Thank you very much.